Assalamu alaikum. I would like to congratulate the leadership and the organizing committee of Pakistan Society of Hepatology on the successful 21st annual conference. It is not an easy task to arrange a meeting of this magnitude during the COVID pandemic. Unfortunately, because of the restriction, I'm not able to travel, but looking forward, inshallah, to see everyone next year. The topic I was given today is to discuss about safe prescribing of medications in chronic liver disease and cirrhosis. Looking at my outline, the first thing we will discuss about what are the response of drugs in patient with chronic liver disease and cirrhosis. Does patient with chronic liver disease and cirrhosis are at increased risk of drug-induced liver injury? What are the common polypharmacies or drug interaction we see in patient with chronic liver disease, and then discussing about these four groups of drugs like statin, beta blockers, proton pump inhibitor, and treatment of tuberculosis. When we're looking at the drug response overall in chronic liver disease and cirrhosis, the response can be altered or can be unchanged. Therefore, a therapeutic effect of a medication can be increased or decreased. Same as the adverse event or side effects can be increased or decreased as compared to general population. Response does correlate with how severe your liver disease is. And unfortunately, at this time, there is not a clear marker before we prescribe the medication that we can say, okay, this patient are increased risk of liver dysfunction with a certain medication. Therefore, it is important for us to understand that how chronic liver disease and cirrhosis can affect the drug response, and we need to also have a better research into this field. There's several potential changes that happen in cirrhosis that can have an impact with the medications. First of all, we know that there is an impaired hepatocyte, so it can alter the metabolism of the drug. Hypolipidemia, when you have low albumin and hypoalbuminemia, there's a less protein, so increased drug concentration. Focal shunting and reduced hepatic flow can have a higher bioavailability of the medication. If you have ascites, it can increase the distribution of volume of the drug. Portal gastropathy can affect the drug absorption. Same with increased bilirubin can decrease bile excretion and increase drug concentration. Renal dysfunction can cause the effect and the strong concentration of the medication. And ultimately, you have a loss of CYP metabolic activity P450, and therefore the medications can have a reduced first pass hepatic metabolism or clearance. And this is one of the reasons that budesonide we don't use in patients with advanced liver disease or cirrhosis because of this first pass hepatic metabolism of its as a mechanism of its action. Now, there are certain things that when you have an increased pharmacodynamic effect of certain medications, the one thing that can happen is it can precipitate hepatic encephalopathy. And classically, we see this in patients who are getting narcotics and opioids, anxiolytics, and sedative. Then you can have a precipitation of acute kidney injury, renal failure, or worsening of GI bleed, and these are mostly seen in NSAIDs. Now, there's also a decreased therapeutic response that can be seen in patients with chronic liver disease and cirrhosis, and mostly seen with beta blocker, diuretics, and codeine effect. The first question we always need to think about it, or we talk about, is does the patient with chronic liver disease and cirrhosis are at increased risk of drug-induced liver injury? So going back that there are medications that have like more response or drugs that have been reported to have an increased hepatotoxicity in patients with liver disease, and their evidence are the first class is anti-tuberculosis medication. And the common one are INH, pyrazinamide, and rifampicin, and this is very commonly used in Pakistan. HIV medications, antiretroviral, methimazole for thyroid, methotrexate, valproic acid, vitamin A, nifacetone. So these are some of the commonest agent that has been associated with increase in the hepatotoxicity. There are other compounds like antibiotic, but this has been commonly, and there are with evidence. Now, this is an interesting study from Asia that looked at the patients who had underlying liver disease, especially hepatitis B, and and they looked at the drug-induced liver injury because of anti-TB treatment. So they had 319 patients who are anti-TB treatment, and then they have control. They have used like hepatitis B positive. Now they use the word carrier, which we don't use anymore. However, patients with hepatitis B on TB treatment, they have more suspected drug-induced liver injury, which was defined as when the ALT was greater than 1.5 upper limit of normal and 2 consecutive occasions within 4 weeks. And as compared to patients who does not have hepatitis B or controls of hepatitis B who were not on any treatment for TB. And most of these episodes of ALT elevation were also seen with increase in HBV DNA. So there was some evidence point towards that patients with hepatitis B on anti-TB treatment had a more increase of drug-induced liver injury. So the drug-induced, DILI is the drug-induced liver injury network in the US, which has been going on for many years. They looked at specific in their prospective study that they found that 10% of patients with drug-induced liver injury had pre-existing liver disease. And the most common, like they had these pre-existing liver disease and then had drug-induced liver injury. And the highest frequency they saw was with a very common prescribed antibiotic in the United States, azithromycin. These patients who had pre-existing liver disease had more frequency or effect of it. But the other thing that has noticed that increased that if a patient with chronic liver disease or pre-existing liver disease, they have drug-induced liver injury, that increases their all-cause mortality and liver-related mortality. And these were all clinically or statistically significant. So if a patient with a chronic liver disease or cirrhosis have a drug-induced liver injury, they have a more chance of getting sicker, and had also based on this study published in Gastroenterology 2015 based on DILI network, also have increased all-cause mortality and liver-related mortality. So looking at the most common medication that we use in cirrhosis are beta blocker, proton pump inhibitor, then there is a slew of diuretics, statins, diabetic medication up to 30%, antibiotics, cardiac medication, and the pain medication. For the interest of time, I'll talk about some of these medications, including beta blocker, proton pump inhibitor, statins, and the TB medications. So polypharmacy is very common in patients with cirrhosis. There was a study done, and it showed that on average, our cirrhosis patients are on 5 average medications. There are obviously medications that are patients who are much more medications than that. And adverse drug reactions are very common. And some of the common reactions or adverse reactions that we see in these patients are hyperkalemia, hypoglycemia, nephrotoxicity, and precipitation of hepatic encephalopathy. The common drug-drug interactions are all, and especially trainees, need to know that our potassium-sparing diuretic with, if you're using angiotensin receptor blockers, that is a common causing hyperkalemia. If you're using beta blocker with insulin causing hypoglycemia, using benzodiazepine with opioid, then cause increased risk of confusion and worsening hepatic encephalopathy. And if you're using diuretic with NSAID, renal injury, hyperkalemia, and combination of these side effects. So there are, also the common medications that has been associated with drug-related event, again, are furosemide and spironolactone, sedative, NSAIDs and opioid, antimicrobial, beta blocker, and potassium supplement. So whenever you're using these medications, you need to look at the other medication. In the US, we do have pharmacists when we prescribe these medications to help us, and that not available in Pakistan. So you are the first and the last line of defense for a lot of these patients to make sure that if you're prescribing any medication based on the liver history, you need to look at the other history also and make sure they're diabetic medications, they're hypertensive medications, there are other medications that are not interacting with any of the medications you are prescribing. So let's talk about the statin. This is one of the most commonly used medications in the world, and drug-induced liver injury related to statin are extremely rare. So let's take the state, less than 2 cases per 100,000, and these reactions for statin use are mostly idiosyncratic. So first point, which you all know, that statins are very safe in patients with liver disease. And the common indication for statins are hyperlipidemia and coronary artery disease. Now, the bigger question that comes in, so if you have a patient who have coronary artery hyperlipidemia, you should not worry about starting statin. So that is no-brainer. Now, the question is whether expanding the indication of patient of chronic liver disease cirrhosis will have some effect. And there was There is data about whether it improves the anti-inflammatory and anti-fibrotic property. Have this because of statins, these properties, then it can help with patients with portal hypertension and chronic liver disease. For some of these earlier evidence start coming out, there was an amazing study published in 2016 in Gastro. They had a randomized controlled trial of patients who had a recent variceal bleed, and they had a band ligation plus beta blocker, and then the other arm was plus band ligation beta blocker plus statin. So they added a statin on top of beta blocker versus placebo. 158 patients, they stratified by the Charles score, and they used simvastatin 20 milligram. 5 to 10 days post-bleed, and it's escalated to 40 milligram dose by day 15, which is slightly a higher dose, I would say, followed for 24 months. The primary outcome is that whether they will have an effect on rebleeding, but then they didn't see in the simvastatin arm in red and placebo in gray or black did not have any change, so they did not reach the primary outcome. However, interestingly, in the secondary outcome, they saw that patients who were on statin, they had improved survival after the variceal bleed. So 17 patients in the placebo arm versus 6 patients in the simvastatin died in it. So this was first of the evidence that patients who were in statin, in addition to getting regular, beta blocker and variceal band ligation, had a better survival at 24 months and providing some evidence. Now, there's also retrospective some data of about 40,000 men in the VA from 1996 to 2009, patients who were all compensated hepatitis C cirrhosis patients. And statin were associated with decreased risk of decompensation and mortality, and these were adjusted for age, albumin, MEL score, and Charles-Lee score. So latest, there is a study which was LIVERHOPE-SAFETY study published in Lancet Gastroenterology and Hepatology 2019, and they looked at the safety of 2 different doses, doses of statin and rifaxim. It's like a randomized controlled trial, phase 2 Charles PNC, and patients were 3-armed to receive simvastatin 40 plus rifaxim of different dosages, simvastatin 20 plus rifaxim and placebo. And primary endpoint was development of liver disease or toxicity. So based on this, that patients who are in a higher dose of simvastatin and rifaxim were associated with a significant increase in ALT and AST and CK level, requiring treatment withdrawal compared to simvastatin. So patients who were decompensated cirrhosis on a higher dose of simvastatin had some side effect. So the statin is such a popular that there is a lot of interest that's going on. There is a new network that is just established by NIH called Liver Cirrhosis Network, and fortunately lucky to be one of the principal investigators out of the 10 sites in the US. That one of our idea or one of our goal is to consider a statin clinical trial, and we are working on it, and hopefully we will have more information. So in summary, for statin in chronic liver disease, the retrospective and randomized controlled trial have shown benefit of statin in cirrhosis. We do need additional randomized controlled trial with hard endpoint before statin can be recommended for use in patients with chronic liver disease. However, if your patient have a clear indication of hyperlipidemia and coronary disease, statins are perfectly safe to use. However, patient with advanced liver disease, Charles-Lee score and high dose statin can increase the CK level and need to be monitored, and need to monitor for interaction with statin. Now let's move to beta blocker use in cirrhosis. This topic has been discussed many times, so I'll kind of glance through some of the data which you already know. First of all, the earlier in 2010, there was a starting having this question whether the beta blockers had a more deleterious effect on patients with liver disease, especially refractory ascites. So the first single center study, which was observational study of 151 patients with cirrhosis and refractory ascites, found that patients who are on beta blocker had a much higher rate of mortality or decreased survival. So 1 year survival was lower in patients who received propranolol, 19% versus who did not. And that has brought a lot of discussion that beta blocker were not safe in patients with advanced liver disease, and especially with patients with ascites. But when you look at it a little bit deeper, that patients who were on beta blocker arm, they were much more sicker. 70% of those were Child-C. Their bilirubin was elevated, their sodium level is low, and they had a low blood pressure as compared to patients who were not. So there was definitely some data. It wasn't a randomized control. There was a significant group. The mean dose of propranolol was much higher, 113 milligram per day. And cause of death in 97%, like 97 patients, 50 were then from sepsis, right? And 13 had ACC and 25 were unknown. So we cannot make those decisions based on this study, which was not well done. It wasn't a randomized controlled trial. So then there was also some data start coming out that, incidence of death was actually lower in patients with refractory ascites who were on a non-selective beta blocker. And this was looked at it at patients who were on non-selective beta blocker. There was an increased incidence or they have a lower. And then when they look at the outcome, which is on death on wait list in patients who were no selective, and then carvedilol was one of the things that was coming out as one of the factors. And so the thought was that this was more related to the blood pressure because carvedilol effect, which is both alpha and beta, that can cause low blood pressure. So it's not the propranolol or other thing, it's carvedilol, and it's more related to blood pressure, and that's where the more discussion. And this also in study with actually a post-hoc analysis of 3 randomized controlled trials evaluating satavaptan for hyponatremia for ascites management, and they looked at it. And in that, large study, about more than 1,100 patients of 3 randomized control, they did not see any increase in mortality in any subgroup, whether they were on high dose non-selective, low dose non-selective beta blocker, or they have refractory ascites. So that was the other thing that was found out. However, patients who were, and this is again, patient who had refractory ascites and diuretic responsive ascites, there was no difference. So Pavino recommendation for beta blocker right now, and there's a new Pavino conference, which is, I think it's happening this month or next month, likely next month. We're gonna have further, but in patients right now in cirrhosis and refractory ascites, non-selective beta blockers should be used cautiously with close monitoring of blood pressure, sodium, and creatinine. Until we have more randomized controlled trial available, we should either reduce or discontinue non-selective beta blocker in patients with refractory ascites if they develop. So if they develop any of the following feature: the systolic blood pressure is less than 90, if they have hyponatremia and acute kidney injury. And carvedilol should not be used in cirrhosis with ascites because of the data I showed, because of the low, it causes more low blood pressure. And also in patients with ascites, avoid the high dose of non-selective beta blocker, which is defined as nadolol greater than 80 and propranolol greater than 160 milligram per day. So there is an interesting study now on the other side, where this study, which was published in about 2 years back, and they wanted to look at whether non-selective beta blocker can prevent decompensation in clinically significant portal hypertension, which most of you understand defined by hepatic venous pressure gradient of greater than 10. They included patients who had no ascites, no varices, or very small varices. They randomized to 2-arm non-selective beta or beta blocker arm, which is propranolol or carvedilol versus placebo, and the primary endpoint was decompensation, and that followed the patients for 3 years. So in this, it was interesting, like that patients on beta blocker has a decreased cumulative risk of primary endpoint, which is decompensation. And overall, the mortality was also lower in patients, and mainly because it prevented the development of ascites. And this was the study. So in patients on a beta blocker arm, there is a reduced reduction of hazard ratio of 0.42, which you can see here has in patients with a beta blocker arm. So 9 out of 10 patients, 100 patients in beta blocker arm versus 20 in placebo had developed ascites. That was one of the main reasons that the patients on beta blocker arm did not have decompensation and have improved survival. And so right now, I think that, as I mentioned, the beta blocker should be used very cautiously in patients with refractory ascites, and if they have acute kidney injury, hyponatremia, those are and low systolic blood pressure, then you have to stop the medication. Lastly, quickly, proton pump inhibitors. So this is one of the most commonly used medications worldwide. In 2015, PPI is ranked the top national health expenditure in the US. Evidence regarding association is predominantly based on observational study, and you can use it that there are many different associations that has been used with proton pump inhibitor. It is most prescribed class, up to 40% patient in the US is on medication. The interesting thing is that 2/3 of these patients have no indication for the use of PPI, And these are all metabolized by the liver. And they have been associated with increased risk of SBP, C. diff, and worsening hepatic encephalopathy. Again, most of these observationals or most of these studies are observational and cross-sectional by design and provide a very conflicting results. And PPI-related acid suppression, however, can cause intestinal bacterial overgrowth and translocation as possible causes of these effects. When I was preparing for the talk and have presented before, one thing which I learned that PPI guidance is based on like liver disease severity, although no one uses it based on the insurance, but I just wanted to provide that there are patients who have advanced Child-Seed disease, they may be unsafe, and esomeprazole may be. Again, we don't have randomized controlled trials. This is more pharmacy data, but I just wanted to bring it up. Lastly, tuberculosis treatment in patients with liver disease, especially cirrhosis. First of all, there's a major challenges in treatment of TB, especially if you have chronic liver disease and cirrhosis. The burden is huge, and you all are experts of this. I'm just giving what I read, as we don't see TB in the US. However, there's no consensus or guideline, and drug-induced liver injury likely risk is very high in patients with chronic liver disease and cirrhosis. And I already showed you data. If you do have a drug-induced liver injury in chronic liver disease, the outcomes are poor. And monitoring is very hard in these, but it need very close monitoring if you have a patient with chronic liver disease and cirrhosis on TB medications. And there is one study which I was reading about, and this is a slide I took from Saqib from one of our close friend in England, who has been also a participant in PSH. The 25% of pulmonary TB cases had chronic liver disease in Pakistan has hepatitis C or hepatitis B. This is a paradigm that we see that hepatotoxicity of the first line drug. So the red is like more hepatotoxic, so pyrazinamide and INH as compared to aminoglycoside or ethambutol. And these are some potentially hepatotoxic combinations. So if you use INH, rifampin, and pyrazinamide, and less hepatotoxic agents are aminoglycoside, caprimycin, ethambutol, fluoroquinolone, cipro. So we work very closely. If you do have a patient with TB and require this treatment with our infectious disease doctors and pharmacy, to look for less hepatotoxic patients. If you have a patient with cirrhosis, especially advanced cirrhosis, you need to be paying very close attention to these hepatotoxic effects. And these are one of the paper I was studying that they have been recommendation for anti-tuberculosis treatment based on child A, B, and C. And in child C patients, no hepatotoxic drug can be used, and second-line agent like streptomycin, ethambutol, fluoroquinolone should be used. Duration can be extended because you're using a second-line agent, and caution with aminoglycoside, and same with the different categories if you have child A or child B disease. Now, lastly, I just wanted to mention about us in the COVID pandemic that we are using several therapies. And it's important to know what their effect on the liver injury. So if you're using dexamethasone steroid, there is no dose adjustment or liver test effect. However, remdesivir has been associated with some mild elevation of liver enzyme, although we don't need any dose adjustment if you have cirrhosis. But in the clinical trials and some studies, like 5% had grade 3 increase of liver enzyme and 2% grade 4. And the package insert say that if your ALT is greater than 10 times upper limit of normal, these remdesivir should be stopped. Tocilizumab, which is the IL-6 inhibitor, also you don't need dose adjustment, but it has been associated with 3% causes of elevation of ALT 5 times upper limit of normal, and you stop it if the ALT or AST is greater than 5 times upper limit of normal. There's no dose adjustment needed, but just want to let you know. However, tocilizumab can cause thrombocytopenia, and especially in your cirrhosis patient, you need to monitor it. So in summary, safe use of medications in patients with chronic liver disease and cirrhosis continues to be an ongoing challenge. Lower doses are recommended for the use of most drugs in cirrhosis. Outcome of drug-induced liver injury, if that happened in chronic liver disease patient and cirrhosis, is poor. Polypharmacy and adverse drug effect are very common. It's very important that you are ordering medication to know the drug interaction of these medications. Statins use are safe in liver disease. However, we need further studies to understand the benefit itself in liver disease, and especially in cirrhosis and portal hypertension. If you have a patient with cirrhosis with ascites, you avoid carvedilol. And if you have a patient on PPI, you need to understand why this patient is on PPI. If not, you should stop the PPI. And this is the end of my talk. Thank you so much.